Now, I'd like to welcome everyone to episode 6 of the Aspire web series. It's Endometriosis, Surgery versus ART, and that's the title we're speaking to tonight. I'm joined by world experts in both IVF and surgery, and we're very lucky to have Dr Suresh Nair, who's an obstetrician and gynecologist in the Seed of Life Fertility and Women's Care Medical Centre from Singapore, which is where our conference is going to be held annually this year. Dr Tran Nguyen is from Adelaide. She's a fertility specialist and she works at Embrace Fertility Clinic, but she also is an expert endometriosis surgeon and is going to talk a little bit about PRP with us tonight. Professor Angela Aguilar is a professor in REI and ONG at the University of Philippines College of Medicine. And she has an interest in reproductive medicine, but also in pediatric and adolescent gynae. And many young girls are diagnosed with endo. So it'll be great to hear her perspectives on that. But she is also a past president of the Gynae Endoscopic Society. And Associate Professor Moamar Al-Jefout works as a consultant and a surgeon in the United Arab Emirates University in UAE. And we're very, very fortunate to have a panel of absolute fertility experts, as well as very, very experienced surgeons. And they are going to be able to tell us tonight about some of the really difficult decisions that you really need to make on the basis of your experience. So I have several questions that I'm going to put to our panelists tonight to get their expert opinion. And I'm going to start with Associate Professor Moamar Al-Jefout.
Yes.
We're going to start at the beginning, Moamar.
Yeah.
What is your approach when one of your patients who you know has endometriosis comes to see you and wants to conceive? What do you start telling them about what they could be doing?
Okay, Louis, thank you very much for the invitation and to be in the company of such a high standard experts. You know, it depends when you are dealing with endometriosis, fertility related to endometriosis issues. It depends who you are as a clinician. Are you a surgeon? Are you a reproductive endocrinologist? Or you are a mix of them? You see, and this is really, I've seen that it's making a difference for what decision will be taking, which direction the patient will go. For me, myself, I'm a bit mix of two. And, you know, while getting my white beard a little bit, I'm changing my attitude towards things. 10 years ago, I used to chop everybody. Now I'm holding my horses and starting to think. And few factors needs to be taken into consideration. First of all, the age of the patient. It's very important. Which early reproductive age, late reproductive age, did make a big difference for decision. The second one, the phenotype of endometriosis she is having. And I'm talking about clinical phenotype, and I'm talking about pathological phenotype. Either it's an ovarian endometriosis associated with deep endometriosis only, or not associated, or it is a solely superficial endometriosis. This is make a difference. The second one, the presence of clinical phenotypes, which is pain with infertility, infertility alone, or pain. Or maybe there is none of them except infertility. This will depend upon the severity of the symptoms she's having. The second thing, the previous reproductive experience she had. She had IVF before, she had reproductive surgery before or not, she had cystectomy for pain or endometriomas or whatever. The second, the next thing is, and a very important thing is the ultrasound findings, or what do we have? How extent the endometriosis? Is it mild, moderate, or severe? And I like to classify like them. And finally, what's her ovarian reserve? Is it good, bad, or optimal, or excellent? And the last thing, many of our colleagues are forgetting, the presence of comorbidities. And I'm talking about adenomyosis, polycystic ovary syndrome, fibroids, because when you have a combined reason for causing this infertility, maybe it is the adenomyosis that's causing the infertility rather than the presence of endometriosis itself. Maybe it is the polycystic ovary syndrome that is dominant. And I think the old golden wisdom of treating the patient, not the disease only, and individualizing the approach for the patient is very important. I will start with the standards, looking for the patency, ovarian reserve, the general condition of the patients. And one of the most important things, I tell my patients, you need to have hope. You need to walk in the psychological level to these patients, because the word infertility, I don't like to call them infertile women. I call them women with delayed childhood. That's a childhood bearing. You know, it's a delayed process, because if he has a sperm, she has an oocyte, there is always a chance. And I don't like to put things white and black. No, you cannot get pregnant until you do IVF or surgery. Always give a hope and a margin for maneuvering. I don't want to be longer than that. We will have more.
And indeed, many people actually conceive naturally too.
Yes.
So
yes. That's very important thing. I can give you hundreds of cases who underwent lots of surgery, lots of IVF, and they get said we will do nothing. She become pregnant after 6 months alone, spontaneously. So please, we are not gods. We just consult our patients, but we need to have this with a philosophical approach. You know, the guidelines are there. We all know them. For mild, moderate, ovulation induction, you know, for deep, maybe surgery, ART, depends upon. But you need to individualize your approach. Not all of them it's not a conveyable bill. It is a patient with a certain problem. You need to address all her needs and explain to her and explore possibilities of getting with minimal intervention.
So talking to that, Tran, can I just ask you, are there certain vitamins or are there things that you can offer a patient who maybe isn't ready to move to either surgery or IVF that might help them? Do you have any advice in terms of lifestyle or other supplements?
Supplements, there's many, and I think it's the antioxidants that we need to focus on. Because endometriosis, the peritoneal fluid, is considered potentially inflammatory. So anti-inflammatory is the way to go. The most common one that I would suggest is CoQ10, 300 milligrams per day, and that has shown to be anti-inflammatory. There's some suggestion that fish oil, vitamin E, vitamin C can help as well, but the evidence is probably still emerging there too.
Angela, can I ask you a question? Because we've talked about someone who is ready to have a baby. What do you do, given that you do a lot of peds and adolescent gynae, what about a young girl who is newly diagnosed with endometriosis, possibly from a scan, but has a low ovarian reserve? You know, what is your approach in terms of preserving fertility or considering what you can do to help her maintain her fertility when she might not even have a partner?
Right. That's a very interesting question, because young women are having access to diagnosis early. That's a very thankful development nowadays. More and more practitioners are screening for endometriosis in young women. And when they are discovered, our first goal is not to take up the scalpel or schedule her for surgery. Our first goal is to suppress the endometriosis. Suppression not just primarily for fertility, but of course to improve their quality of life, because the impact of endometriosis in these young women are immense. Nearly half of university students in our centers have been known to have quality of life that has been significantly impacted in a negative way by endometriosis. with suppression, with improved quality of life, we are able to, by way of reducing the inflammatory effects of the endometriosis in the ovary, preserve their fertility. Now, with regards ovarian tissue cryopreservation or oocyte retrieval, that's still a very, very difficult question to ask, given that we have young women, their access, financial access to these um, technologies may yet be impaired or limited. So that the best you can do is do medical suppression as soon as you're able to identify the endometriosis in them.
And what kind of medications do you use, Angela, when you talk about medical suppression?
So primarily for younger women, for example, in early adolescence that may actually have these types of endometriosis, we may do well with oral contraceptive pills, combined hormonals, but the priority will be progesterone-only pills because any amount of estrogen we know will actually make the endometriosis prosper, and therefore progesterone-only pills or even long-acting progesterone. Sometimes you use off-label etonorgestrel as well, apart from the oral Dienogest. We give these to young women and they will do well with long-term suppression. And data on these progestins have been very reassuring so far, and they can go on it for about nearly a decade or even more.
Fantastic. Suresh, can I just ask you, in people who don't have a partner, what about egg freezing? Do you want to comment about egg freezing for young people who have endo but may not be ready to have a partner or to consider donor sperm? And how would you do it for someone with endo? Do you have a particular way you would think about egg freezing?
Well, fundamentally not too far from the regular way in which we would do egg freezing. I've been a strong proponent of egg freezing for our young women in our country because we only started doing that, approval was only gained just two years ago. The approach I would take is, first and foremost, of course, we have to explain to her exactly what it entails, because many of them might not realize that it involves injectables, it involves a minor procedure, and what if she has concomitant endometriotic cysts as well? Those are very significant considerations because we know all too well there are some complications in egg retrieval whilst we have large endometriotic cysts. To me, the basic principle is to try and, as Moamar said, and all of you have reiterated, to be as conservative as possible, because we know even in the best of hands, even if you do robotic surgery, we will, out of the nature of the way we operate and the nature of our technological advances, it is damaging surgery to a significant extent. So first, do no harm and make sure that we don't get into an irreversible state, because ever so often, and I'm sure all of you have seen this many times before, they come to us as IVF practitioners after the event. Our colleagues with good intentions have removed the cyst wall and said to go into IVF, AMH she might have done, might have been maybe 14, 20, and now it's 2. And what are we going to do about that? You see, so therein lies a situation where we will have to explain to her, you will have to have repeated cycles. They have the mistaken notion that you do just one and done, and we are ready, we've got the eggs. It's also colored by the fact of her age at which this has happened. The older she is, the more compromised with the eggs that she has, in view of the fact that they are higher risk of aneuploidies as well. So the whole discussion has to occur in explaining to her the fragility of human fertility, exactly what the steps are required that she must have to go through with, and also, if possible, involve her prospective partner as well. Because if indeed, and as Moamar also explained, the husband or partner to be, and if he agrees to a sperm analysis, turns out that he's got significant oligoteratospermia, then we are talking about the IVF routes instead of anything to do with IUI or things. It colors the whole decision. It's a combine, it's a pairing of the couple. So that's the strategy I would take. Provide information, provide counseling, provide empathy, and don't be presumptuous, and talk down to anyone who's desiring such treatments, and proceed along those lines.
So would you tend to offer IVF before surgery, just so that you're going to, I don't do surgery, so often surgeons will refer to me before they consider their surgery. Do you tend to be doing that, or do you assess that based on egg numbers? And I'm going to ask the whole panel this. My
tendency is exactly that, because we all know that much as we would like to think we are all great surgeons, whether you do it robotically or not, ever so often there have been instances where we have rendered, even if just the one cyst has been removed in one ovary, a unilateral endometriotic cyst, we excise the endometriosis, or even if you haven't touched the ovary at all, and you've done extensive endometrial excision, ablation, be it rectovaginal or not, and lo and behold, some months later, when you check the AMH, it has come down. Is it a natural progression of the natural history of the disease, or is it something I induced? I don't know. But I don't want to get myself in an irreversible position. So preemptive IVF, and it's got to do with many factors: accessibility, affordability, what kind of healthcare systems is there, and counseling as to whether there are religious inhibitions or things that prevent them from doing such treatment. But information provision is of paramount importance. And to emphasize, why is it that this condition is so shrouded with so many dilemmas that we truly don't have the exact answer? But first and foremost, do no harm and don't get into an irreversible situation. So in a situation like this, let me paint a situation which we've all seen: large bilateral endometriotic cysts. In fact, if you wanted to, if time permits, I have some slides I can show, but I'll just describe it. She came in, she was fortunately 32 years old. I say it's fortunately because youth is ever so important. And she had a reasonable AMH, but I resisted the temptation which her preceding 3 gynecologists had said, remove the cyst first. So what we did was to stimulate, and she went through 5 cycles and gotten about 9 blastocysts, good quality blastocysts. And this perennial problem that we all face, where we have all of the follicles on top of the cyst and none of them in easy access from the vaginal, transvaginal route. So we tend to use the same vaginal probe. You should not use the abdominal probe because we are all not trained to do the abdominal probe. Our amniocentesis colleagues can do it. We don't. Much as we want to imagine that we can, use the transvaginal probe, 2 probes on the table. One, don't use the one that we use in the vagina on top and the abdomen because of contamination. And even the most obese of women, there is a crease. Go at the crease and make sure that area has been sterilized and shaved if possible, and transabdominally pick up all of your eggs. There has been a presentation by a very well-known Italian IVF practitioner who had demonstrated in a big conference multiple points of traversing the endometriotic cyst. That's asking for trouble, because once you've gotten into the endometriotic cyst, abscesses can occur. The vagina is not entirely without any bacteria. And the endometriotic material is so rich in nutrients for bacteria, and you end up with an abscess and you ruin her entire pelvis. So I've always suggested to my colleagues, please don't. That's the wrong message. Do a simple, it's quite straightforward, aspirate your follicles from above. After I've done that, then if you want to do surgery, you have blastocysts banked. You have a certain degree of security. You do the best you can and doing very slow and gentle surgery. There's nothing there's no great pride one takes by doing and ripping apart the cyst wall and showing how fast you can do the cystectomy. This is one instance. Endometriosis surgery is one instance. You must be slow, deliberate, careful, meticulous, and take your time, peel, and do preemptive peeling. I call it preemptive hemostasis. That means as you're peeling it, and in robotic surgery, you got 3 arms, you can easily do it. You're in full control of the camera. You use a microbipolar and diathermize the vessel feeding the cyst close to the cyst wall, rather than having it burst and getting it retracted into the cortex and then using a lot of electrosurgery. Be very careful at the hilar area. If you feel that it is rather treacherous, don't have to peel the endometriosis cyst wall from the hilum, because our ovaries are supplied by an end artery. So you hit that, the whole ovary goes. So taking all these precautions, we try our best to be minimally invasive as best we can in the cystectomy, clear the rest of the endometriosis, and sometimes they conceive quite spontaneously, but we still have blastocysts in the bank. I don't know whether I've had release.
So, Moamar, is that your approach as well? Would you be looking to get blastocysts before you do surgery? And also, do you have any tricks or tips with your surgery to try and preserve fertility?
Yeah, but Louis, before that, let's make it logic. You know, the presence of the endometrioma itself is affecting the ovarian reserve. Inflammation, as Tran have said, and a lot of things. But on the other hand, surgery itself, trauma is a trauma, and trauma is inflammation-producing procedure. And believe me, how much you are a good surgeon, you will take oocytes with you. And Musa have shown that in his study. 50 to 60% of all specimens contain oocytes, and these oocytes are very precious. So first of all, I try to delay the surgery as much as I can. Try to do IVF once, twice, 3 times, failed, then you have clear conscience to go to surgery after consulting your patient. And on the surgery, I try to use cold dissection. Cold dissection. I don't like, I agree 100% with Suresh. I don't like when somebody said, I did a cystectomy for endometrioma in 15 minutes. I know that he damaged that ovary. Take care, clean, cold dissection. Try to avoid using coagulation as much as you can. Maybe laser is better, but the evidence is there's no randomized controlled trials on this. But the other thing, sometimes, I'm not sure, I don't have vast experience in this, but sclerizing putting some alcohol inside the endometrioma itself and do a second surgery. Some studies have shown AMH effect is much less when you are using 2-step surgery. Just put some alcohol there, burn the cyst from inside with this alcohol, and maybe you do an IVF after that, or second, the surgery will be less harmful. But still, we don't have high evidence on this. It's still cohort studies, no randomized controlled studies on these. The other thing, I think we need, it's an ovarian reserve. So yes, I will take and do have on her IVF center some oocytes or blastocysts for the future. Yes, I do believe that it's a good strategy, especially on those with low MH, young ladies, and poor responders.
Fantastic.
She must have that. Another thing, I'm talking again about comorbidities. For instance, in women with PCOS, I don't use other progestins. I only use dydrogesterone for induction. For pain if she's having pain. And I use it from day 14 to day 24 because at the dose of less than 20 milligram, does not inhibit ovulations. All other progestins will inhibit ovulation, obviously. So if she's having PCOS and endometriosis, I will go 3 months for dydrogesterones, less than 20 milligram, 10 milligram for 10 days per cycle. And maybe after that, I will go with letrozole induction before I send them to other ones. This is my humble experience.
Fantastic. Thank you. Angela, are you in consensus with everyone, or have you got a different view? Do you do you consider IVF first, or how do you make that decision?
Well, luckily, we, like Moamar, we also, and Suresh, we also are in the best position to be able to sequence the IVF and surgery in a logical manner because we're able to perform both, and we'll be able to individualize which patients are able to collect eggs first before performing surgery. Because if we remove the endometrioma, sure, you may be able to collect eggs afterwards, but it's going to be 1 or 2 at a time. Eventually, if you get a good embryo, you will have a good chance as any to get pregnant, but it's the egg collection. It's so inefficient because every cycle in a very impaired ovary will only yield only a couple of eggs, and if you're lucky, a good blastocyst. So it's the sequencing of surgery before IVF or after IVF that is most important. So if you're able to have a window to be able to aspirate those follicles without doing any surgery, do so. And then go back, do the removal of the endometriomas, and then do another cycle, collect as many eggs as you can. So you have to lay it out in a long-term plan for the patient so that they don't tire out, they don't get frustrated, they don't expect miracles, their expectation is managed. So always we tell our fellows or registrars that cyst wall is not a cyst wall. In an endometrioma, that's a cortex. That's a cortex that invaginates, and you're not removing an endometrioma. There's just a thin line of endometriotic layers there, but that's the cortex that you're trying to quote unquote strip. So don't do it. If you can just decompress, drain, try to remove whatever is very filmy, and then do a IVF stimulation a couple of months later. You have to prepare that patient for that sequence.
Fantastic, thank you. Now, Tran, you do a bit of a PRP at surgery. Do you want to tell us a little bit about how you do it, and also what the evidence is, but also what your experience is? Because sometimes that is a way people try and get more eggs, and certainly some countries use it a lot.
Sure. So ovarian PRP, platelet-rich plasma, is your autologous blood, and it's spun at the time of surgery. And you need about 40 mils to spin, and it can be there can be a second centrifuge to get the platelet-rich plasma, and that would be more concentrated. It has been used in other specialties, dermatology, joints, and it has been around for over 40 years. But in fertility, it's only been around for less than 10 years. It's been used for ovaries as well as the thin endometrium, but in ovaries, it's to aim to stimulate the follicle growth. And it's for women who have low ovarian reserve, where there's follicles, but potentially when they are stimulated in an ART cycle, the follicles don't have enough FSH response. It is good to do at the time of endometriosis surgery, 2 birds with 1 stone. It has the same surgical risk The ovary is easier to identify over doing a transvaginal ultrasound. However, we have the skill set to do the ovarian PRP vaginally. It's just more convenient at the time of surgery for endometriosis too. It has a surplus of growth factors. PRP can be supraphysiological. It doesn't have to be too many platelets in that plasma. It just needs to be supraphysiological, which means 1.5 to 2 times the amount of platelets, and that can boost the growth factors in that area, such as VEGF, IGF. There are concerns sometimes, theoretically, that it could be a stimulant for cancer, but this has been theory so far. Long-term aspects are still being observed. In terms of what we've seen, there are conflicting data. There are randomized control trials, observational studies. There has been shown benefit for women who have primary ovarian insufficiency, women who have poor response to stimulation in the past. And it's women who are sort of given that last resort. Donor egg is the next step, and the women are not ready to make that decision yet, and they're trying to sort out their fertility and want to try one more time. In terms of harm, there hasn't been many cases of abscess at the time of laparoscopy, because we do give a dose of antibiotics. And vascular injury is less because we are injecting in the superficial layer as well. In terms of endometriomas, I haven't used it for that, but it could help with reducing bleeding potentially, but it is definitely anti-inflammatory, and hopefully that can reduce the inflammation around the endometriosis where excision of the endometriosis has been taken place.
Tran, how do you do 1 injection or 3 or 5, and also how long before you do IVF?
So platelet-rich plasma is spun to 3 mils. That's what the latest systematic review says, that the optimal dose is 3 to 5 mils per ovary. I used to do 1 injection, but the oocytes are around the whole ovary. So I have changed my technique by doing using a smaller needle, a Williams needle, which is used for Botox injection of the bladder. And that needle will allow the smaller trauma to the ovary. And I do I spread out the PRP, probably 3 to 4 injections per ovary.
Right. And when do you consider IVF again?
Oh, yes, and IVF, because of the physiology of stimulating follicles from pre-antral to antral follicles, it would be best at 3 months post-op to do another stimulation. But over that time span, I would say try natural conception, and because you've cleaned out the endometriosis, she's possibly in less pain. It maybe she may not need IVF by the time that 3 months happens. So generally it takes 3 months to reach its peak, and over the next year it will wane, the effects will wane off.
Fantastic.
So the AMH will rise, Tran?
Sorry, Moamar, can you say that again?
The AMH will rise after your injection at 3 months?
So there has been good study protocols to look at AMH, FSH, and antral follicle counts. And it has been shown that the AMH does increase, the FSH does decrease, and the follicle count increases.
But after 3 months, it will decrease again?
Potentially, but it's not that rapid. It could be just a slow one over time.
Okay.
But with endometriosis surgery, as you know, the first 6 months is where the optimal time period is for conception, whether it's IVF or natural. So if we can optimize the fertility during that time, that would be the best.
Fantastic. Now, obviously, there's a lot of communication that goes on between fertility doctors, and I suspect all of you are qualified in both areas. But you know, if you're Suresh, if you were talking to a surgeon or to an IVF doctor, how do you recommend that they communicate together to kind of make sure that they're not just sitting doing their own thing without thinking of the other aspect of that?
Really good question, and it's a dilemma and a problem that we are trying to grapple with in our country. I'm the section chair of the reproductive division in our college, and what we are doing is to have a sort of a buddy system. So if a group of gynecologists, you see a case of endometriotic cyst, I think it behoves you to have a fertility expert at least that you should talk to or have the patient talk to, because medical legally speaking, if ever one has taken out a cyst and you've rendered that patient subfertile, menopausal, in a grave state when it comes to her fertility potential, you have little grounds to stand on if you haven't had a discussion of how best can I do the surgery without damaging your fertility or your ovarian function, and what are the techniques they've used. For example, right down to even what was described way back in the 80s by Adelaide. Most of our healthcare system, insurance systems, doesn't support a two-stage procedure, at least not in our country. So would you have talked about initial drainage and maybe excision of the endometriosis in the pelvis, and then give a GnRH analogs and coming back the 3 months to do an ablative technique? Yes, the recurrence rates are there, but our main emphasis, our focus is on preservation of fertility and getting her pregnant. Or have you talked about the potential of having preemptive fertility treatments? Or if you can't afford it, are there surgical methodologies by which you can minimize the risk? And also, when given, you've got to give her the option, the couple the option of not doing anything. You all have seen many instances where patients come back merrily pregnant with massive endometriotic cysts, and they go through the pregnancy without any problems, or you can come up with problems of leakage and problems in pregnancy, but that's something you need to talk about as well. Not doing anything surgical, but trying to get you pregnant by ovulation induction or other methods as well. So all in all, I would talk to my colleague and say, first of all, the laparoscopic surgeons, when they have their conferences, don't ever get any lectures with the fertility experts. And so similarly, we talk so much about IVF, but we don't have anyone talking to us about the nuances and intricacies of how you should do surgery. And I'm doing most of my surgery now through the robotic method, because I believe, and we've been doing this from 2006, that our dexterity, we have to return to the surgeon the dexterity that he's lost when he can't use his fingers and wristed movements. When you do a laparoscopic surgery, you're using big joint movements. And I know amongst you and many others, there are excellent laparoscopic surgeons, but I'm talking about the masses. If I want to enhance or enable a large number of surgeons to be able to do very intricate, fine surgery, you have to give back to the surgeon what laparoscopy has robbed out of the surgeon, which is the loss of intuitive movements, which is very critical in suturing and fine surgery, the loss of high definition three-dimensional vision, very important in endometriosis surgery, because when I see my initial pelvis by laparoscopy, then I swing the robot in, I see a lot more. And this is a surgically extirpated disease, and therefore vision and accessibility to the lesion is extremely important. And especially when you come to endometriotic cysts, I want to reiterate again, finesse and fine surgery is all important. And when you are in command of the camera, when you are in command of all of the instruments that you have, and you have 2 right hands and 1 left hand, and you're not dependent on a assistant unless he's got a neural track connected to your neural tract. He or she is second guessing your movements and where you want to see. You can do precision surgery. It's all about precision surgery to minimize thermal and mechanical damage to the ovary. So if your healthcare system allows this two-stage procedure, maybe, yes, the recurrence rate may be higher, but maybe ablative surgery enough to have us conceive, maybe by simpler methods, letrozole, as Moamar mentioned, SOIUI, or maybe IVF, because not all of us have access to IVF. So this is what I would do, and this is what we've been doing in our college as well. A cross-pollination between the laparoscopic surgeons and the IVF practitioners.
Angela, we've got a question from the chat box actually, and it says that this particular person, Feroza Begum, is from Bangladesh. She says, no one can afford 2 IVF cycles. Do you do the IVF before the surgery if there are endometriomas, or do you do the surgery first? What would your recommendation be?
Well, access to care is really a problem. That's why it's a worldwide campaign that will be able to provide women support for their reproductive rights. So whatever is accessible, we have to be upfront with the patient with regards what will be the outcomes. If it's going to be surgery and that's all that is subsidized by their government, then so be it. We cannot promise anything else. For example, if the patient has an ovarian endometrioma that's bilateral, we remove it, but we will be left with a very severely impaired reproductive capacity. At least you decompress and then you suppress. Occasionally, with good medical treatment, sometimes you'll be able to shrink those endometriomas. And that may help when you turn off the suppression, sometimes spontaneous ovulation may happen. But what will be the advantage of surgery is that you can see other pathology that, not apart from the endometriomas, may be corrected without IVF. For example, if there's tubal disease, tubal phimosis, or adhesions that may be restored if it's anatomically feasible doing the surgery. But then, if you have a male factor, then that will all the more remove the entire equation. That's what my addition was when Moamar was talking about the phenotype, because sometimes, regardless of the phenotype, if I have a patient with a severe male factor, never mind all those strategies, optimized for IVF. That's another story.
Yeah.
So that will be a very important strategy for those low resource setting.
So Tran, we haven't talked a lot about what type of stimulation, although Angela alluded to it there. You know, what kind of things would you look medically to either suppress endo beforehand or to run a cycle with? What kind of cycles do you prefer? Agonists, antagonists, long down regs, progesterone primed? What's your view on the cycle you would choose first?
In terms of the severity of endometriosis, I think her track record, if she's had IVF before and how she's responded, I like the antagonist cycle because it's the most straightforward. If she has mild or moderate endometriosis, I think it might be appropriate to definitely mild, and moderate could be a part of that. And if she has moderate to severe, I prefer the long down reg cycle so that she can have some suppression of the endometriosis. If she's aiming not for an embryo transfer in a stimulated cycle, I think progestogen, ovarian stimulation would be great, because then there's less stimulation of the endometriosis, less injections as well, which women love. And they have the convenience if they wanted to do an embryo transfer in the subsequent cycle, or plan it when it's most appropriate for them.
Moamar, have you got a view on the kind of cycle that you would choose first?
Regarding stimulation, you mean?
Yes.
Yeah, so the antagonist, you know, it depends on also factors again. It's what's available to you, what's your experience, and what's insurance you have. Unfortunately, we are facing these. I'm not sure they are so ethical, but sometimes, you know, you need to take in consideration this. For instance, in Jordan, IVF is not covered by insurance. In UAE, a woman will have 4 free cycles IVF every year for free from the government. You understand? It depends upon what's you. Luis, I would like to answer the first question. It's very. Have you seen the first question there?
Oh, the first question.
Yeah.
Oh, yes, please do in the chat box.
Yeah, it's said,
So I'll read
woman
it.
with,
It's
yeah,
a
it's
lady has frozen embryos and adenomyosis and endometriosis, but
yeah.
also a hydrosalpinx.
Yes.
What do you do before you
This
transfer?
is what we are calling. You know, actually, I'm dealing with lots of these complicated cases, and adenomyosis, in my opinion, first of all, it's underdiagnosed, especially in younger age group, and secondly, it will affect infertility, if not equal to endometriosis, maybe more. You know, it's because it is an angry uterus. It's hyperistalsis there. Even if you have good quality oocyte, the embryo transfer will not be successful at all. Not at all, but in most cases. So in this case, you have another third factor, which is nasty, which is the hydrosalpinx, which is a source of all kind of inflammatory process that will be draining within the uterine cavity. So in this case, I had such a case. I did for her bilateral salpingectomy. Okay. I removed as much as I could from the endometriosis, and I put her straightforward into GnRH agonist for 3 months. And after that, I did the IVF stimulation for her. But we are not allowed. I always advise my colleagues who are doing the IVF, please check for the stability and tranquility of the endometrial myometrial interface. If it's, you know, it's obvious peristalsis, don't do embryo transfer. You are just wasting, draining these embryos. So you need to calm down, cool down this adenomyosis by GnRH agonist for 3 months. You have a frozen embryos for there. After that, you can do your ET very nicely. You see, this is what but salpingectomy is a must in such case, because all these will be draining into your uterine and the uterine cavity of this lady. Yes, thank you. I'm not sure if colleagues have another approach for this.
Suresh, what about what stimulations do you choose? Do you have a preference?
No particular preference. As Moamar mentioned, affordability and so on and so forth. Antagonist protocols still work very well. I often have used the PPOS protocol. Some of the patients are already on Visane. So we've done a large number of cycles with Visane on board. Some have Mirena on board. We started doing PPOS in that way some time ago. So that's been thankfully successful. It all got to do with the ovarian reserve. Your eventual ultimate success depends on your ovarian reserve and the age of the patient. To give us symptom relief, because we know endometriosis can churn up the disease as well. We tend to use the progesterone PPOS more and more these days. But we also have used the GnRH long agonist. My problem with the long agonist is, first of all, they have awful symptoms. It's pretty awful. And secondly, I don't get the kind of response that I would like a desire. It's somewhat too much of a suppression. So I've moved away from that, and ever since more established data has come out from PPOS, I've tended towards using Visane or Mirena, more so Visane, because I can, take it off or not. And in between cycles, she can have sort of a drug-free period, but most of the time they get all of the symptoms back again. So I tend to put them all across the period of time. I just want to put forth another situation, adenomyosis. I think we as clinicians and surgeons doing resections and damaging the uterus is not the way to go. In spite of all the techniques that we've been it's been published and proposed, honestly, I think we haven't licked the problem of adenomyosis. So I still am highly conservative. I'm more aggressive in the endometriosis, but I'm very conservative in the adenomyosis. And worst case scenario, if it keeps on not working out, then lies a situation where the concept of surrogacy comes into play, and in the really bad patient adenomyosis patients, because I think we haven't got that sorted out yet.
Angela, do you have any comments on adenomyosis? Do you have any special techniques when you're getting implantation failure? And with endo, we tend to think the eggs are getting the quality there is important, but with adeno, it's kind of more implantation, really. Do you have any tips for us?
Well, yeah, thank you. We just wrote an editorial piece in our journal on adenomyosis. And the only problem with data is that it cannot be sorted as neatly as we can. Because when you look at data in terms of intervention and outcomes, it's a hodgepodge of adenomyosis, adenomyoma with different phenotypes. And classification is still not standard for many systematic review in vitro analysis. So that's the issue that we have. Hopefully, we'll be able to overcome that with the use of the MUSA, or morphologic ultrasound criteria, and we will get better data with better classifications. Right now, it's still suppression. Suppression, even with GnRH agonist prior to embryo transfer, not prior to ovarian stimulation, but prior to embryo transfer. That may be our best bet. That's the only problem. Yeah.
Can I just interrupt? If you're doing a suppression, then would you normally do an artificial cycle, or would you use some FSH? How do you, once they're already on a long downread?
Yeah, so when you suppress, try to shrink that adenomyosis using GnRH agonist. The only problem will be it takes quite a while to wake up that lining. And sometimes the faster lining will be achieved when you're doing FSH. Okay, so that is the trick, or maybe just the short experience that I have with regards trying to wake up that endometrium after suppression of the adenomyosis. So that's an issue that we have to battle with, and hopefully we don't reach what Professor Dr. Suresh is asking about surrogacy, because that's still not available. I would not say not available, but it's not available or legal in the Philippines as well.
So one of the questions we had was, how do you campaign to help people preserve their fertility and do fertility preserving protocols, like politically? Do you have any comments on that? So when societies don't give you that option,
we have two organizational approaches to this. Let me go macro. For example, we're in the special interest group of endometriosis, and we're advocating for centers of excellence on endometriosis. So I believe with a lot of campaigns in social media, people search anyway, and we have referrals from people who see us in social media. When we are able to tell them that we have a center of endometriosis with all the specialists working together, not making the patient go back and forth from one specialist to the other, then we'll be able to deliver high value care. So we're campaigning for that. Hopefully we'll get more centers accredited across Asia. And with also Moamar was the president of the Asian Congress, Asia ASEA, Asian Society of Endometriosis, we'll be able to get more specialists to come together and talk among themselves on how to approach without, battling it out and saying one technology or one approach is more superior than the other. So the multidisciplinary care, it will be the best way to go. And among Asians, I think we'll be able to succeed.
I'm going to ask Moamar,
Yes,
and
ma'am.
in fact, I'm going to ask the entire panel. When you have people with endo, you sometimes get to the point where there are hardly any eggs and the AMH is very, very low. And indeed, we've got someone talking about a person who's 43 with an AMH of 2, and they got very small numbers of eggs each time, nothing fertilized. At what point and how do you mention donor eggs? Where does donor eggs come in? And how do you do that and talk about it?
Okay, Luis, I will cut it short on this. In Jordan and UAE, it's forbidden to have donor eggs.
Right.
Donor sperms. It's illegal. So most of these patients will go to you in Australia, Luis.
They can come and see me in
to
Tran.
Singapore, really. Many of them are going to Singapore or to Australia. When I worked with Ian Fraser late, I have seen all of them, but still a debate, ethical debate. And
do people just keep trying? Them, particularly if they get 4 free cycles?
Yes. You know, we are not in a very good position into this, and sometimes you just desperate. You don't know what to do, and the only thing you can do, just keep encouraging them, supporting them as much as you can. Look, life is life. We are not, and there is a potential for each of us. But the main thing, keep supporting them and don't let them be desperate, because desperation is awful. Just say to her, we will keep trying, seek second opinions. Look, I will be looking into this PRP. Thank you for your, you know, we don't have it. We have it for other aesthetic surgeons are doing a lot of it, and they're making a lot of money from it. So maybe now I will start exploring their technologies, and maybe we will have some hope for some women. But this is what I can tell you about this, Luis. This is the real life. And maybe there are, you know, I'm not sure how can this philosophically, you know, women at some stage, they themselves, they are very intelligent. They understand, maybe it's not meant to be to have babies. Let me focus on myself. And I always tell them, don't fight with endometriosis. Fight for your health. This is very important.
Thank you very much.
Yeah.
Now we've got about 2 minutes here. I might just ask that same question of the last 3 speakers. Tran, very quickly. Donor eggs, when do you mention that? When do you bring that up as an option?
I try to broach her earlier and offer her empathy. I think that's all we can do. And like Moamar says, women are intelligent. They know when they're exhausted with all the treatments, and they know when to stop. And they just need that validation that it's not going to work. And we want to give them an option, but they can take their time with it and doing it early so they can have that adjustment period.
Suresh, when do you breach that topic?
As part of my general description of IVF, I just put egg or gamete donation is one of the components from the beginning. And by gentle persuasion, if I see that things are not working out, it's a gradual introduction that, you know, if only we had good eggs, if only you had been given an opportunity to have frozen your eggs when you're younger. But there's a way. In Singapore, egg donation is allowed. It's even doesn't need to be, she can herself, the couple can bring an egg donor of a choice, and we can do it. The government encourages that, as opposed to having her go to repeated cycles. And then she comes to the realization that maybe, yes, it's better to have and start my family and have my baby grow within me, rather than, you know, sometimes I make a comparison. of someone who's had to have a surrogate and she doesn't have the attachment to the baby, and make it seem that it is a good thing to do for her, because I also have my other patients who are very happy to talk to my prospective egg donor patients, and sharing and learning from each other. And, sometimes I make the comment that ironically, they're so well matched that the baby looks still a lot more like mommy rather than daddy sometimes, So all of these are just little positive things, telling that it's not so bizarre a thing. And we live in an era where this technology is available, and you can be a mother too, and slowly, maybe eventually ease her into that realization that maybe I should have an egg donor.
Now we're running out of time here, Angela, but you get the last word. What about
Thank you. Yeah, well, that's why I'm in the adolescent group as well, because that is where we can have earlier intervention. And with comprehensive basic sexual education, they'll be aware of their fertility, they'll be aware of their menstrual symptoms, and they'll access care earlier, so that we don't deal with women who have ovarian reserve late in the day. Earlier, they're able to note if there are pathologies that need care, then the earlier we'll be able to intervene and save them from perdition of childlessness, so to speak. So that is it. Thank you.
Fantastic. Well, it's been a fantastic hour. I must congratulate all of you on being able to answer all these tricky questions. None of them are straightforward, and all your experience absolutely helps all of us. There are a couple of questions in the chat box that we might just handle individually, and I might ask you to help me with that, particularly on PRP trends. Some missed some of that. But I would like to thank you all so much. I just feel your expertise and your experience, but also just the ability to explain the empathy you have for your patients in tricky situations makes a huge difference, and it's a great learning for all of us. So thank you, and thank you for taking your time.